I am railroading the working sleeve over the dilator. So we have landed at the spinolaminar junction. Here the bevel is facing medially. We are removed. Yeah, if you want to avoid fogging of your camera, so this is how we have put a gauze piece and we are trying to secure it in the place. Yeah, this is how, because we are going to apply the covers. The advantage of the cover is repeatedly if the saline falls on the camera system, so sometimes again the image gets blurred, again we have to disconnect and clean it, so it will unnecessarily consume a lot of time. So if you see here, we have already applied cover onto this. So this is how we try to do. See, the advantage of putting gauze piece is it will try to take any humidity. Hold the camera. Yeah. So once this is done, there is some sticker which we can secure it in place. So this is how we have done covering of your endoscope, and there is a gauze inside so that it will take the humidity, so that there will not be any fogging. We use normal saline for irrigation purpose. The advantage of using normal saline is for removal of debris, for better visualization of the neural structures, as well as it causes retraction of neural elements when we cut open the ligamentum flavum. So using normal saline, we can use it by gravity method or fluid pump method. So the settings on the fluid pump, it should be not more than 50 mm of Hg of pressure at a rate of 0.4 liters per minute, and at any given point of time, even if there is profuse bleeding, we should not increase the pressure beyond diastolic pressure. That should be the optimal settings. If you see here, we are using a side firing RF or plasma probe to shrink the tissues in order to delineate the bony anatomy very well. So our landing point was at the spinolaminar junction. So the best way is straight away dock our sheath on the bony structure. That would be better, because if you try to float above the lamina, unnecessarily the muscle will creep in and will land up in removing too much of muscle. Post-operative MRI, if you see, there will be lot of removal of muscle. So instead, directly land on the bone, start burying. You can use a diamond burr or a cutting burr. If you use a cutting burr, then you can do your job quickly. But for a beginner, it is better to use a diamond burr, because diamond burr, the advantage with the diamond burr is the bone dust can be pushed into the bleeding crevices so that it will not be a bloody field. So here, if you can see here, the way I am burying the bone is a woodpecker model. Either you can do a side to side burying or a woodpecker model. Woodpecker model, the advantage is you can speed up your work, but there are certain disadvantages too. Now if you look at here, my 12 o'clock is the base of spinous process, my 6 o'clock is the junction of IAP and the lamina, 3 o'clock is a caudal end, and the 9 o'clock is the caudal part of L4 lamina. I am trying to shrink the tissues with the help of a side firing RF probe. So our first target is base of spinous process, then caudal end of the lamina. Then we start burying onto the medial edge of IAP till the tip of IAP. Then we make out the junction of lower lamina, SAP and IAP junction. Now you can see here I am using again the cutting burr, the base of spinous process, lamina as well as IAP, the medial. So how much amount of medial edge of IAP has to be burred is the question of the hour. So just in order to free the soft tissues, we are not supposed to burr more than 1 or 2 mm in the initial stages till we see the SAP. Now you can see here I am facing cephalidly. I am trying to burr the tip of IAP. Now I am again shrinking the soft tissues. So see, now here you have to remove all the soft tissue. Exactly, we have to make out the cranial aspect of L5 lamina, which continues as SAP, and even the tip of IAP, everything you have to make out. And then if possible we have to remove the superficial layer of ligamentum flavum, so that we can nicely make out a proper anatomy. So now again you see, with the help of a kerrison I am trying to take out the superficial ligamentum flavum. and trying to chip off some amount of medial edges of SAP in order to decompress the lateral. Five-year-old female patient with 455S1 stenosis, critical stenosis. Patient is conscious under isobaric spinal anesthesia. You can see here. Yeah, you can see here. Yeah. Yeah. This is a thecal sac, and this is the cranial end of lower lamina. This is caudal end of upper lamina. This is opposite side. You see opposite side, this is SAP, IAP, my side, this is SAP, IAP. You see opposite side, I am standing on the patient's left side, I am retracting the nerve root. You see, yeah, that's the L5 traversing nerve root. This is the axilla here, and this opposite side. You see, beautifully we have done even annuloplasty. And this is my side, done over the top decompression, and this is my side. You see, yeah, this is my side on the left side. This is L5 traversing the root, and We have done over the top decompression. You can see here that's a thecal sac. Opposite side. That's a end of surgery. Yes, and you must.
మీ పేరు ఏం పేరు? మీ వయసు ఎంత? ఓకే.